Coming up on the FSR Sarc Fighter Podcast, what kind of doctor should be treating your sarcoidosis? Is it a rheumatologist? Should it be?
But for many different reasons, we've never taken a strong role in terms of taking care of patients with sarcoid.
Dr. Arthur Yee of Hospital for Special Surgery in New York City is a rheumatologist with an interesting take on sarcoidosis.
And I would conjecture that many of the medicines that are currently being developed for rheumatic diseases will eventually segue over into the sarcoid world as well.
My conversation with Dr. Yee is coming up on the FSR Sarc Fighter Podcast.
This is the Sarc Fighter Podcast, living with sarcoidosis and other rare diseases. Here's your host, John Carlin.
Well, hello, this is episode 132 of the FSR Sarc Fighter Podcast. I'm your host, John Carlin. The date of this recording, February 16th, 2025. Man, it has been a heck of a winter, and it is not letting up. It's mid-February, and I live here in the mountains of Western Virginia. We've had more snow than usual, along with lots of freezing rain, you name it. And there's more snow in the forecast as this week progresses. So, man, that really stinks. And I got to tell you, where we live, every 4 or 5 years, we'll get a big snow, like 20 inches. And it'll stick around for a little while, and then it's gone. And a typical winter, we might get 2 or 3, 4 to 6 inch snowstorms, but that snow lasts a week, and then you get a bit of a reprieve. We'll have temperatures that'll go up into the 50s, and it'll be sunny, and the snow is all melted, and so you can just kind of wait it out. And we have a basic amount of plowing and that kind of stuff that people do, but for the most part, you everything gets closed, and you just wait it out. But this winter has not been like that. The snow comes, it gets cold, and it stays cold for 2-3 weeks at a time, highs in the low 30s. And I'm just not used to this anymore. I grew up outside of Syracuse. I've recently been back up there this winter, and yeah, there's literally 2 feet of snow. I grew up in a little place called Salisbury Center, New York, right in the foothills of the Adirondack Mountains, and but that was kind of normal growing up, although they haven't had snow until this year, like they did when I was in high school back in the 70s. But anyway, it's been a tough winter, and I'm getting cabin fever. I'm not loving this. I went out and rode my bike outdoors on January 1st, and I think I talked about it. It was a cold, nasty day. But I was determined to start the new year off. Going to get out there. I'm going to keep up my cycling activity. And I don't usually need a lot of motivation, but it was symbolic. That ride was miserable. I'm not going to lie, it was. But now I'm getting cabin fever, something awful. And wherever you are, I would expect that it's more of the same. I know the national forecast for the Northeast is looking even worse than it is here for the next week, and we're looking at another potential snowfall of 6 inches or more in just the next couple of days after this podcast is released. But there is a little bit of hope on the horizon, the proverbial light at the end of the tunnel. In my backyard, for as long as we have lived here, the previous owner had planted a bunch of daffodils. And so daffodils are a bulb plant. If you're not, if you don't have a green thumb or whatever, they're a bulb plant. So they come up every year from those same bulbs, and they are somewhat impervious to the cold weather. And I've seen them push up through the snow in the past, right? So the snow doesn't bother them, frost doesn't bother them, that kind of stuff. They're bulletproof, so to speak. And when we had that last snow that stayed, I said, man, I'm never going to see those daffodils. Well, We did have a couple of warmer days in between, and the snow melted, and the daffodils are coming up. So they're up out of the ground about 6 inches right now. And those are my harbingers of spring. I can watch those things coming up out of the ground, and the backyard is brown and everything else is a mess. And here are these little patches of green, and pretty soon they'll have those pretty yellow flowers. And some of my guy friends make fun of me. Oh, I hope your daffodils are pretty. Fine, whatever. But I'm waiting for those to do their thing, and then you know that the rest of spring isn't far behind. So there is those green patches, splotches in my backyard are the light at the end of the tunnel, and they are there, so you know it's coming. Okay, and I can't complain too much because I did get away for a week at Disney World. It was warm down in Orlando. We had one cold day, but then it was really, really warm. My sons are members of the Disney Vacation Club, so they get preferential everything. And that was nice. So now they're taking me to Disney after I took them when they were little. And we stayed in Animal Kingdom Lodge. You could walk right out on their balconies, and there's giraffes. They're just standing there, just looking at you. It's like having a lodge in the zoo, or if you will, and I've been to Africa, right out there with the animals. Of course, this is much more carefully curated than the wild animals I saw in Africa, but there were giraffes, there were all kinds of antelope, zebras, exotic birds, you name it. They were all just kind of standing out there. And of course, the people know to put the hay down on the ground for the zebras and the I want to say gazelles, but I don't know if there actually were any gazelles, but for the antelope. And then they reach up with a ladder and they put whatever giraffes eat, maybe it's hay, up in the trees so the giraffes can feed normally, and they get up and do that right at sunrise, and then the animals appear and you sit there with your coffee. And I could have sat there all day and watched the animals and never gone to a park. Right? I could have stayed right in the hotel and been perfectly happy. And one night we did a nighttime safari, and we got to go out and actually be closer to those animals in the back of a vehicle with night vision gear, and we could look right at them. And that was really fun. And my grandkids, 4 of my 7 grandkids were with me. We had a great time watching them do all the Disney things and seeing their eyes light up. And my oldest grandson Luke, there was a bet, an over and under on how many of the thrill rides that he would actually do, and he did do Flight of Passage, which is a really, really cool ride where it's like you're on a motorcycle. You get onto a device that looks like a motorcycle, and then it's a virtual ride that absolutely takes you through the movie Avatar as if you're flying on the back of, I want to say dragons, and I'm going to say the wrong thing, and but whatever. It's really wonderful and scary. And he did that, but the actual roller coasters and the Tower of Terror, he made it into the little elevator that begins the Tower of Terror, freaked out, and we had to get him off before he went nuts. And this was after a whole year of psyching himself up. But, it was fun just to fun. It was memorable being there with Luke as he attempted to undertake some of these scarier rides. But that's okay. He'll grow up, he'll grow into it, and he'll be pulling us along. And then the thing that we really, really got into as a family was pin trading. I can't remember if I talked about this in the last podcast or not, but everybody's got this collector gene, or many people do, and I guess I have it. I think my sons have it, my grandkids have it, my wife has it. So we got into the pin trading thing big time. And the way it works at Disney is a couple of ways. Of course, you can buy new pins, and they're very expensive. They're on the order of $15 a piece, which I think is expensive. They can be as low as 12, or you can buy like the mystery packs that might have, say, 6 or 7 pins inside. And I'm collecting Goofy pins, and my wife is collecting 101 Dalmatian pins, and my other son is collecting Pluto pins. All right. So if you open the mystery pack and you got something that was in the family collection, you'd give them that pin. And then the rest of them that were not pins that were in your wheelhouse, you can walk up and at just about every cash register in Disney, there's a pin board. And it's just simply take a pin, leave a pin. So you walk up to the pin board and see, is there a Goofy pin that I don't have? Is there a Pluto pin that Jonathan's looking for? Luke was looking for Stitch pins, and apparently Stitch is the most coveted or collected pin character right now. So there's a gazillion of them. But that made it easier to find ones that he didn't have. I would have thought the same would be true of Goofy or Mickey, and it's actually not all that true. It's been my experience. So you just take a pin or leave a pin, and then at Epcot, there's a pin store, and outside that pin store, the serious pin traders show up, and they've got their pins all spread out on these sort of foam rubber boards, so the pins just kind of stick in there. You don't have to use the back on them. So you can just stick the pins in there, and you walk up to these folks, and they have to agree to the trade. It's not just take a pin, leave a pin. They have to agree to the trade, and they've got all the common pins. So they don't say yes to a lot of what you propose, but they have got, I don't know, hundreds, thousands of pins. And so I walk up and I'd say, would you take this for a Goofy pin? And the lady would smile and look at me and say, no, thank you. I have that pin. She's being very polite, because now that I've looked into it and read some of the blogs about this, what I was asking her to trade would be like, would you give me $1 for a penny? Would you give me $100 for a penny? It's kind of like that. But it's also interesting to see how it works. And lights were going off in my head like, I guess I got to go in and buy a recent collection that maybe she's trying to complete, and maybe I've got a pin that she doesn't have yet. And I had a little bit of success with that, and certain other serious traders are looking for certain things. But it was kind of fun to be near greatness within the pin collection world. But we really, really, really had a lot of fun with that. So, and the warm weather. Just being down in Orlando. Again, we had one cold night, and then it was in the 70s every day. You'd start out with a sweatshirt on, walking around in short sleeves by the end of the day. That did help me get through this terrible winter. So anyway, that's kind of what I'm thinking about right now. But I want to talk a little bit more about this. I want to talk about my guest today. He is really interesting. Dr. Arthur Yee at Hospital for Special Surgery in New York City. And it's associated with Cornell University. Cornell, the university center itself, is located up in central New York, but the hospital portion of Cornell is in New York City, and that's where Dr. Yee is. So, Ivy League, big time hospital, and he is a researcher, but he also treats patients and he teaches as well. And he not only treats sarcoidosis as a rheumatologist, but he is a sarcoidosis historian. He can tell you everything about the origin of the discovery of sarcoidosis, to who did it, to some milestones along the way, the various medications that have been approved or mostly not approved for sarcoidosis. And we talked a little bit about Humira, which is a drug that I have taken. I now take a biosimilar for Humira because my insurance company insisted upon it. But he was one of the first, if not the first person to recognize the value of Humira, which I'm guessing is a rheumatological drug first and foremost. as an inhibitor, a TNF inhibitor, to treat sarcoidosis. And he told me that he started sampling with it, and you'll hear him talk about this, and I don't want to mischaracterize it, but he said that Humira, the drug that he was testing, maybe it was in mice. I can't remember. We'll have to listen to the interview again together. But it wasn't even called Humira yet when he recognized that there might be that drug out there that could be valuable to treat sarcoidosis. And remember, it's still off-label. I've had success with it. A lot of patients have had success with it, but it's still not recognized as a drug that is on label for sarcoidosis. But he can talk about this much, much better than I can. He really articulates some wonderful thoughts about the process of treating sarcoidosis. And one of the other interesting concepts or theories that he has about the cause of sarcoidosis, I had to ask him about that, right? He doesn't think there's a single cause, but he does believe that certain people are predisposed to have sarcoidosis, and it doesn't show up unless they encounter some kind of a trigger in their lives. Something that hits their body wrong, that all of a sudden their body starts with this autoimmune response, inflammatory response, and all of a sudden sarcoidosis is there. So we talked about some of the triggers, and he talked about everything from the dust at 9/11 to beryllium miners to people who have tattoos. All of those things are, in his mind, as somebody who studies sarcoidosis, are things where you can see that if you can't necessarily trace the cause and effect, you can see, wow, a lot of beryllium miners wind up with sarcoidosis. A much higher percentage of people who breathed in the dust at 9/11 got sarcoidosis than you see in the general population. And also people who get tattoos. There's something about the immune response to whatever's going on with the tattoo process. So, and he mentions all that stuff and talks through it a little bit. I thought it was absolutely fascinating. So a very interesting conversation with Dr. Arthur Yee at Hospital for Special Surgery in New York City. And it's next here on the FSR Sarc Fighter Podcast.
A zombie just feeding and stumbling.
Hi, I hope you're enjoying the Sarc Fighter Podcast. You may be wondering, what can I do to help? How can I be a part of the sarcoidosis solution? It's simple. Make a donation to KISS, Kick In to Stop Sarcoidosis. 100% of the money goes to the Foundation for Sarcoidosis Research. Look for a link in the show notes of the Sarc Fighter Podcast. Welcome back to the FSR Sarc Fighter Podcast. Joining me now is Dr. Arthur Yee at Hospital for Special Surgery in New York City. And Dr. Yee, thank you so much for joining me on the podcast today.
Well, thank you for inviting me. I'm always happy to talk about sarcoid.
Tell me a little bit about your practice there in New York, first of all. And you just told me you're affiliated with Cornell University?
That's correct. Yes. The medical school is located in New York City, and my hospital is one of the hospitals that under its umbrella.
Got it. And so what percentage of your patients are dealing with sarcoidosis?
At this point, quite a number. I never turn away a sarcoid patients when someone calls for an appointment. My staff knows that. So I'm a rheumatologist. I've been in practice for 30 years. And my interests have been in the area of not just patient care, but also patient education, research. What we like to do here is the triple threat of patient care, research, and teaching. And I like to keep involved in all three aspects of those. We all do here, but my interest has been in sarcoid and has been for the past 25 years.
And why sarcoid in particular?
Sarcoid appeals to me in so many different ways, and I can't say it appeals to other people in the same way. I like puzzles, and sarcoid. Every patient with sarcoid is an unique situation and a unique puzzle that needs to be solved. And to me, that appeals to me, but that's the same reason why sarcoid has been very difficult to study over the course of the years, because it escapes categorization, it escapes pigeonholing, and so it doesn't fall neatly into a discipline all the time. I mean, while the pulmonologists have had the strong hand over the past many decades, I think we've gone beyond the point where we can just say that sarcoid is a lung disease. Now, you'll hear a lot of pulmonologists still say that, but I think that those that are currently being trained recognize that lungs may be commonly involved, but it's not a lung disease per se. It just happens to affect the lungs frequently, as you know, as anyone who is sarcoid knows.
Absolutely. And I've had a lot of folks on this podcast, patients who, have the pulmonary version. That is by far the most common, but the cardiac and neurological patients as well. I've had folks on here with, of course, skin sarcoidosis, but spleen, multi-organ involvement,
Absolutely.
very, very common to the people who are talking publicly on the podcast. And I know that you were involved, quoted after you spoke at a conference, and then there was an article that came out mid last year that I'll link to. But you said you never turn away a sarcoidosis patient, but some rheumatologists do. What's going on there?
Yeah, so that's really interesting. I personally feel that sarcoid fits firmly into how rheumatologists are trained. For people who are not in the know, rheumatologists deal with a lot of unusual conditions that deal with aberrant immunologic mechanisms, and also diseases that involve many different parts of the body at the same time. So we're actually very familiar with like lupus can affect many different systems at the same time. It's one of our diseases. But for many different reasons, we've never taken a strong role in terms of taking care of patients with sarcoid. So my message has always been we need to get more involved. I think primarily it's a question of training. Our fellows are not trained to think of sarcoid as one of their conditions. HSS, I've tried to put in the effort that, hey, you should be able to take care of this very easily. It dovetails very nicely with what you already know how to do with other diseases. And so I've taken it on the road, is the bottom line. And I think the message is getting out. But to your point, the governing body of our discipline, the American College of Rheumatology, have a registry called the RISE registry. And it has like many practices around the country that are enrolled in it. And so they actually have a sense of how many sarcoid patients are being seen around the country by rheumatologists. And to cut to the chase, about half of the about half of the sarcoid patients in this registry are seen by only a sixth of the rheumatologists. So there's a very much of a skewing of where the sarcoid patients are being seen in our world. And that's just not correct. We all should be familiar with the condition. When I gave a presentation in San Diego at our national conference, two of my colleagues and I were on a panel, and we basically packed a ballroom. Rheumatologists are really interested in learning about the condition, so much so that the fire marshals actually came in and removed people because we were breaking fire code. So they brought them to another
Really?
room with, yes.
Really?
Yeah, I mean, there's a great hunger amongst rheumatologists to learn about the disease. And yet, if you went over to the abstract area where research is being done, there were less than 10 abstracts amongst like thousands of abstracts on sarcoid. So there's a great disparity between what we're doing or what we want to know in the clinic and what our research leadership is engaged in. So it's really unfathomable why there's this disparity.
Doctor, your history is so interesting with respect to what's going on in sarcoidosis, and you do come from the rheumatology side, and I'm not sure because there's so many specialists involved. If when I was first diagnosed, rheumatology was the first place they sent me, for instance.
That's actually unusual, but
Yeah, well,
congratulations.
well, at the hospital system that I was at, I was diagnosed, and rheumatologists started showing up in my hospital room. But you were sharing with me that you were one of the first people to use a TNF inhibitor like Humira to treat sarcoidosis. Can you take us back to the origin of that?
Sure. So actually, I did an MD and a PhD at NYU back in the 80s, and um, some of my research dovetailed with a chemical at the time known as tumor necrosis factor, or TNF. And other researchers had determined that TNF was absolutely essential for granulomas to form. And so this was in mice. And if you had mice that didn't make TNF, they couldn't make granulomas. So in the lab that was adjacent to mine, they were playing with reagents that they developed that would bind to TNF. So they made an antibody that would suck TNF out of the system, so to speak. Well, fast forward a few years later, they took the same reagent and they invented Remicade from that in a matter of 5 or 6 years, and Remicade became an approved medication for rheumatoid arthritis. So in the late 90s, I was referred a case of a woman who had profound diarrhea, uh, and we eventually diagnosed her with sarcoid as the cause of that.
Hmm.
But because of her gastrointestinal problems, there were no medicines that she can actually ingest that would stay in her body. So we were stuck. We knew the diagnosis, but we didn't have a treatment that she could accept. Well, it happened that that was a time where Remicade came out as a treatment for rheumatoid arthritis. So we decided, based on our knowledge of how granulomas form, that it requires TNF, and now you have a targeted TNF antibody. We gave it to her, and it was a miracle. So her diarrhea stopped, all her other manifestations of sarcoid stopped. We published it, and that was the start of a completely new era of treatment for sarcoidosis. As you probably know, people always start with steroids, um, and that is somewhat old school. We still use steroids because they work quickly, not because they're more effective, and certainly they're much more toxic over the long term than many of the other medications we use. So what rheumatologists have introduced into the conversation is the idea that we can use medicines that might work more slowly, but over the long haul, more safely. So medicines like Imuran, methotrexate, Remicade, Humira, and all these biosimilars and generics of the like, those basically rheumatologists have used in many different diseases. And I think that's where rheumatologists come in. Rheumatologists are really knowledgeable about these medications, in addition to being knowledgeable about, multi-system conditions, but the specific medicines that are widely used now for sarcoid originally had their origin in the rheumatology world. And I would conjecture that many of the medicines that are currently being developed for rheumatic diseases will eventually segue its over into the sarcoid world as well. So in your case, you were very lucky to be, I think, involved with a rheumatologist from the very beginning.
Well, I guess I was. I think I was. I'm flummoxed here a little bit because, gee, you look at a granuloma and you say it needs TNF, and so now we come up with something that is a TNF inhibitor, right? And and it seems to work. It's worked for me. I'd taken Humira, and my insurance company eventually said that's too expensive, so we're going to give you the closest thing too, but it's still a TNF inhibitor. And yet, it's not on label for sarcoidosis. It To me, the layperson, it seems like, wow, there's an obvious connection there. We've got a proven track record that it works, and yet the insurance companies don't want to pay for it. Is it just because of the expense?
I'm not an insurance executive, but I can
Sure.
only conjecture that that's the case.
Yeah.
Um, in terms, so I don't know if the layperson is fully aware of all the regulatory things that are going on in terms of getting medicines approved. There's a difference between what the FDA approves and what insurance companies will actually pay for.
Right.
Um, I mean, it's actually, I don't know if you're aware of this. There are only two drugs that are FDA approved for sarcoid. One is prednisone or steroids of some sort, and the
Right.
other is a molecule where you inject and you stimulate your body to make its own steroid. So in effect, it's a steroid also. And
Huh.
those are the only ones that are formally approved for sarcoid. Every medicine that you've spoken about up to this point, with the exclusion of steroids, is off-label. And what off-label is that there's no FDA approval for that particular medication. It doesn't mean that people like myself haven't, proven to most people's satisfaction that Remicade or Humira or methotrexate work. They do, but that's different from approval. Now, for insurance companies to pay for it, that's a separate issue entirely. I mean, I think that for the most part, if you look at the forms that we have to fill out all the times, and I want to emphasize to your listeners, how many forms we fill out to get a medicine like Remicade or Humira approved for you. I want that out there right now. But sarcoid is listed as one of these conditions where we can check a box. It's not other anymore. So it's like rheumatoid arthritis, psoriatic arthritis, Crohn's disease, and sarcoid is often listed on the paperwork. So the
Hmm.
insurance companies recognize that it's an effective treatment. That's very also different in terms of whether or not they will pay for it.
Right.
Because, so I
Right.
don't know, that was a roundabout explanation of I don't know how things work.
You don't know how things work, but I just know that every year my doctor in Cleveland would have to reapply,
Yep,
and it would be a process. It would be denied. It would be denied. It would be denied. Meanwhile, I'm running out of medication,
yep.
and then eventually at the 11th hour they would approve it. Until the last time when they didn't, they said you need to use the biosimilar version. I guess that's a fancy word for the generic version of Humira.
That's a way of thinking about it, but that's a different conversation. So biosimilars are not strictly generics.
Okay.
Um, but if you want to talk about it, we can. But I get your point. I mean, for the layperson, it doesn't really matter.
Yeah, right. Well, so far for me, it's still working, and I am that's anecdotal, but I'll
Knockwood.
take it.
Yeah,
I'll take it.
knockwood. Yeah.
You have studied the origins of the discovery of sarcoidosis extensively. It goes back to the 1800s.
Yeah, so yes, the first description of sarcoidosis go back to I think 1869. I have a interest in history, and it actually helps me understand this disease a little bit better as well. So there was a doctor who was a dermatologist in England named Jonathan Hutchinson. And he first described what he called Mortimer's malady because the name of the patient he saw was named Mortimer.
Okay.
And it was a skin rash. And for people who have had sarcoid skin rash, they tend to be kind of lumpy and bumpy and sometimes comfortable, some I'm not comfortable, but uncomfortable, and sometimes asymptomatic, but otherwise it's there. And for maybe I'd say half a century or more, it was deemed as a dermatologic disease.
Hmm.
They recognized pretty early on that patients did have other non-skin types of manifestations, but it was still kind of seen, okay, well, here's like psoriasis. It's a skin disease, right? Um, Even the name sarcoid was coined by a dermatologist in Scandinavia, a doctor named Boeck, Boeck. The first diagnostic test for sarcoid was devised by a dermatologist, a doctor named Kveim, Kveim. And that was the case until maybe the middle of the 20th century, the 1900s. And what did we get in the middle of the 1900s? Well, we had X-rays. So, so our vision, our view of sarcoid is in part driven by our technology. So by being able to now look inside the body, we're able to see the lungs for the first time. And that was the sea change, first sea change. What was once a dermatologic disease became known as a pulmonary disease. And both in the UK and the US, there were people working on this. In the UK, there was a man named Scatting, whose name is still around because the radiologic staging of sarcoid still bears his name. And in the United States, there was a man named Stoltzbach right up the street here at Mount Sinai. And he actually was the first person to use steroids for sarcoid. And so you have I mean, they were giants in the field and their legacy lives on. And much of the legacy is to our benefit. But I'd say two elements of the legacy we are trying to push against right now. And the first being that sarcoid is a lung disease. You'll still hear people say that.
You say it's not. What is it if it's not a lung disease?
So I would say this is an immunologic disease,
Okay.
which happens to affect the lungs in a lot of people.
Right.
But if you read the literature, there you'll see quotes up to 95% of patients with sarcoid have lung disease. I say that's not true. Those studies came out of pulmonary clinics. So of course, everyone who went to pulmonary clinic had lung disease. So it was a selection bias, right?
Okay.
The other part of the legacy, which we're pushing against, again, as we sort of alluded to before, is that steroids is the foundation of therapy for sarcoid. And I'd say it can be first line in many patients, who have very severe manifestations like either heart or neurologic symptoms. Yeah, we don't want to miss a chance to treat quickly. So we use steroids. They work tomorrow, okay? But with that with that kind of philosophy, you fall into the trap of just throwing steroids at it all the time when it may not be appropriate for other manifestations or other cases of sarcoid.
I'm so curious. You seem surprised that my first doctor was. I'm just using myself as a case study. I'm not trying to make this about me, but people who listen to the podcast regularly sort of know my deal, so it gives them a baseline. You were surprised that my first doctor was a rheumatologist, even though it's my spinal cord that's affected. They didn't send a neurologist, they sent a rheumatologist. But I also look at lupus and I look at some of the other drugs, and it seems like the main menu of therapies do come from rheumatology, do they not?
They do, absolutely. And I think in that article that you cited, I put two timelines. One looking at rheumatoid arthritis and another looking at sarcoid, and where certain medications were introduced for that particular disease. So the same medicines, steroids, anti-malaria medications, methotrexate, TNF inhibitors, and a new class called JAK inhibitors. We've used those medicines several years in rheumatoid arthritis before they were introduced for sarcoid. So yeah, you're absolutely right. The medicines that we use dovetail nicely over your disease, and that's the role of rheumatologists, as I said. And the reason why I was a little surprised that you were introduced to a rheumatologist first is that oftentimes you might have been referred to a pulmonologist, even if you didn't have a lung disease at that time, because sarcoid had fallen under the fiefdom of the lung doctors.
And that's so when I go to Cleveland Clinic, my lead there is a pulmonologist. Although
Dan Culver,
right?
Is it Dan Culver?
No, it's Dr. Ribeiro, but
Oh,
Dan
okay.
is
Yeah,
Dan is
yeah,
there. He runs
yeah.
that clinic, and then Dr. Moss is my neurologist. And whenever I
Uh-huh.
go, I see both of them, and they very nicely tag team, and they always set it up so
Yeah.
I can see them in back-to-back appointments, and they're very considerate of my time. But they do work very well together.
Well, I think you're,
Conversely,
you're
yeah,
pointing to one reason why so much of a challenge to take care of a sarcoid patient, because you need doctors that are willing to collaborate.
right.
Uh, and you can find doctors that, I mean, we have places all around the country that have these collaborative teams. The name of my organization here is called the HSS Sarcoidosis Collaborative.
Hmm.
Um, but the issue comes um, because it's hard to find them all in one place, and have people really take an interest in that particular patient. And each patient is different, right? So you have a neurologist and you have a rheumatologist, and because everyone has a pulmonologist, you have one too. But the way it works best is if they're all talking to one another and knowing that no one person has a monopoly on knowledge. So if I see a patient, like we were talking about a moment ago, of a person with uveitis, I don't know how to look at an eye as well as an ophthalmologist. I need to count on my ophthalmologist friend to do that for me. I mean, they actually have special instruments for that. So she's kind of like my blood test, and I will respond with medicines and adjustments of medicines in kind. And she doesn't know my medicines. So even if she sees inflammation go in the eyes, she doesn't necessarily know how to use or know what side effects to look out for, because that's not, part of her everyday routine, where it is mine. So the point is that because you need optimally a collaborative effect, it's hard to do studies. It's hard, as we've already discussed. Where do you even put sarcoid in the world that we've set up, where you have nephrologists and pulmonologists and neurologists? Where does it belong? It belongs everywhere and nowhere at the same time. So in my talks, I often start with a picture of little orphan Annie, because it is the true orphan disease. It doesn't have a place. Its place has to be a village, and we have to build that village. And that's the way you have to deal with this particular condition, more so than any other condition that I've ever dealt with.
Yeah, well, it is so gratifying to hear you talk about the fact that the collaboration is needed, required, valuable, all those things. And I can just speak from experience that that is not always the case. Sometimes it's ego. Sometimes it's just personalities. I don't know what it is. I had two doctors from different disciplines on the same floor that would not talk to each other and could not agree on the best path forward for me. I don't know what's going on. I don't know which one to believe. And boy, that was awful frustrating. I finally worked through it, but by moving on. But I'll tell you, it was frustrating.
I hear the frustration, and I see it regularly. I think rheumatologists are known for not having too much of an ego. Maybe
Okay.
that's a plus there. But and the other piece of the puzzle in terms of this collaboration, really, you represent, and that is the patient side of things. We have to listen more to our patients. Many studies have shown that what is important to the patient isn't really on the top of the list for the clinician. So if you go to a lung doctor, they're going to have breathing tests and all, and, oh, you're normal, the chest X-ray is stable, whatnot. And meanwhile, you can barely get through your day without needing to take a nap, and you're fatigued and everything else. Those are other challenges. That's another part of the collaboration that we're trying to work on. So we have a pretty active patient group here. They have a quarterly meeting where they discuss, what is of interest to them. So then we get a speaker to speak to them, and it's driven by their interests. And so we want
Yeah.
we want to hear from the patient.
Yeah. Well, I appreciate that. I really do. So what do you think is the state of sarcoidosis right now and treatments moving forward. And if someone is listening here who's a patient, which is probably 80 or 90% of the people who listen to this podcast, what do you think is the state of the treatment of sarcoidosis right now, 2025?
So as you've already figured out, I'm interested in history, and so you can't know what the state is now until you appreciate where the state was 30 years ago. So we're much better off now than we've been ever, for many of the reasons we've already outlined. I would draw the analogy of being at the beach and you're kind of like in the water. You're not in the deep shark infested areas, but your feet are not firmly on the ground just yet. But the tide is bringing you in. And as opposed to where you are, which isn't great, or taking out to sea, which is even worse, I think that where we are is in a good place, and definitely a better place than we had been. And all signs are, for the most part, from the medical side, pushing us into a even better place going forth. And in large part due to this collaboration that we've been talking about. The barriers are going to be cost, are going to be on the government side, on the industry side. And that, I don't know how you guys feel about Virginia, but we're kind of like dying here in New York. But it's that's really the bigger barrier to China, and that's why organizations like FSR are so important, to really understand what the current barriers are to how what we need to overcome to succeed going forth. So I'm optimistic from the
Okay.
standpoint of sarcoid. I'm optimistic in terms of new medications down the line, repurposing of medicines that we already use. All those things give me a lot of optimism.
And so if somebody doesn't have a rheumatologist on their care team, should they run out and get one?
It's not as essential as, say, I think everyone should have an ophthalmologist, because I mean that's a very special skill, and eye disease is pretty common in sarcoid, so you don't want to miss that. Yeah, but I'd like to pat ourselves on the back and say we deserve a seat at the table.
All right. And if you call a rheumatologist and they say, "Oh, sarcoidosis, I don't want that case," then just call another
Well,
one.
so that's on me. That's on
Okay.
us to educate my colleagues, which is why we've taken the show on the road. But there's a great deal of curiosity and receptiveness to the message. In medicine, there's an adage: you see one, you do one, you teach one. So it's just a matter of showing people and convincing them that you already have the skill set. It's just in a different setting.
Right.
That's what we're trying to do.
Dr. Yee, what do you think causes sarcoidosis?
Um, well, I really don't think that sarcoidosis necessarily is a single disease as much as is a common pathway. Um, um, and so what I'm getting at is that it's going to be a combination of what the patient immunologically is susceptible to, and what they may be exposed to. And they're going to be different from patient to patient. A good illustration of that is that after 9/11, a number of first responders developed what was very similar to sarcoid. Obviously, these are people of different backgrounds. Immunologically, they had maybe some common thread, but the common thread was the exposure. And
Right.
so when
To
they
the dust.
right, the
Yeah.
dust, right, they breathed in the dust, and then that, and somehow whatever their immunologic substrate allows them to do responded to that dust, that resulted in what we can call sarcoid or sarcoid-like. So I don't think that there's one particular cause, nor do I think that genetics explains everything. It's really the interplay between the inside and the outside that determines whether or not someone develops sarcoid or not, and whether or not it involves this part of the body or that part of the body.
So you need
Tattoos
some.
are another thing.
Oh,
So so
tattoos?
tattoos are another thing. So there's tattoo
Really?
sarcoid. So yeah, so tattoo, the pigment in tattoos will often react the way same way as sarcoid. And my fellows whom I teach know whenever they're assessing someone for possible sarcoidosis to look for tattoos and see if there are lumps or bumps. So we have had several patients who, started with pulmonary symptoms and suspected sarcoid, but you don't want to stick something down their throat to do a biopsy for obvious reasons. But if you can examine the body and see a tattoo and a lump and biopsy that and see the granulomas, you have your diagnosis without being invasive.
Is there a
So,
cause effect there, or is it just I mean, is that a
oh,
trigger?
again, as I said, it's the body is immunologically primed to react to things in a certain way, and now you've introduced a pigment from the tattoos, and that's how your body reacted to that pigment.
Huh.
And it responds. So when you treat the lung disease, the lump goes down. So it's part of the same immunologic loss of regulation.
So you think that people who have sarcoidosis were exposed to some kind of a trigger, and then so that the immunological response happened because of the trigger, and it doesn't happen for everybody. Not everybody who breathed in the dust at 9/11 got sarcoidosis or
Correct.
sarcoidosis-like symptoms, but a higher percentage than normal of the population did because of 9/11.
Absolutely. Yes, absolutely. Yeah. And you see this in beryllium miners. Beryllium is a chemical,
Yeah.
and beryllium miners developed a higher rate of sarcoid-like ailments. But on the other side of the coin, you see families, with multiple members with sarcoid as well. So again, there's the inherent side of things. There's something genetically, immunologically primed for people to respond in a certain way.
It's I think there's a feeling out there that if we could just figure out what causes sarcoidosis, then we could cure it. And it doesn't sound like it's that simple, is it?
I don't think so. I don't think it's like, I know you're in tobacco country, but it's not like saying, you smoke, you're going to be more likely to get lung cancer. It's nothing like that. I do think that all the treatments that we dealt with has to do with how to dial back the immunologic response to something. And it's possible that in certain cases, the trigger has come and gone. So, in those cases, maybe those are the cases that there's eventually resolution without treatment, you know? Whereas if you breathe in dust and dust is always in you, then there's always a trigger for it, then that's why it doesn't get better. Um, so certain infectious organisms, like there's certain bacteria that are related to tuberculosis, but not tuberculosis itself, have
Hmm.
been thought to be a trigger. We all carry it in ourselves, so it's not like they're rare. They're just in and around us. The bacteria that causes acne has been implicated. And how many people have acne, right?
Right.
So, it's so again, the trigger may vary from individual, but to your point, it speaks to the idea that we may not be able to cure it if we think of it as one disease, right? And work now is out there looking at subsets. Maybe we can identify those patients where we can look towards a cure. Um, I have published a group of patients who uh, who required steroids and then went to methotrexate and other kind of medications of the like. And I eventually got them on a TNF inhibitor, and they went into complete remission on medication, got them off steroids, but they stayed on their, Humira or the Remicade. And then by, mutual agreement, we decided to stop the TNF inhibitor. And I have like, about a dozen patients who have gone on for up to 11 years without needing any medication for sarcoid. And I'm thinking as to why there are patients that can do that. And it has to do, I think, with the idea of shrinking the granulomas down for a long enough period down that they can't self-perpetuate.
Oh.
And so they don't reignite, shall we say, as long as you suppress them long enough. I mean, this is all kind of theory. So you asked me, do I have a theory? And yeah, I think, Mark Judson, who's like the dean of sarcoid in the US right now, has been writing about, well, how come we're not interested in finding a cure, for sarcoid in that manner? I don't think we're going to go back to the original where it starts, but we can certainly deal with where it is or might head towards.
Where's is Dr. Jensen located?
That would be Judson, Judson.
Okay.
Mark, Marc. He's in Albany.
Albany
Yeah,
Med in New York.
yeah, yeah, yeah,
Yeah. Okay. I've had some folks on through FSR at Albany Med before, but I don't believe I've talked to
yeah,
Judson.
yeah, yeah.
Huh. Interesting. Well, I'll tell you what. It's just you said you like puzzles. You picked a good one.
Yeah, I mean, it's to me, it's really it, I feel like I can contribute to this group of individuals. I want to because they need help. I think I have the skill set. I think rheumatologists have the skill set to help. Um, they just have to be shown that they have the tools necessary.
So should I title this podcast "Calling All Rheumatologists"?
That would be great. Um, you'll still see rheumatologists that say, "Well, I don't want to deal with that one." But then there are other rheumatic diseases that I don't want to deal with, so I can certainly understand that.
All right. Dr. Yee, thank you so much for joining me today. I really appreciate
Oh
it.
no, my pleasure. It's great to meet you. I hope I can meet you in person one day. I do make it down to your neck of the woods every now and then, so
Okay.
I'll be sure to look you up. Or if you come up to New York.
All right. Yeah, I'll be in New York at least once this year. So maybe if I get the opportunity, I'll stop by.
Wonderful. All right. Well, don't hesitate.
I feel like a zombie, just feeding and stumbling.
So thanks again to Dr. Yee. That was really interesting and informative, right? And so a couple of takeaways. It's not one disease per se. It's a common pathway, as he puts it. He says we need to face that trigger, and that's what causes Sarc to erupt in our bodies. And I know that there's concern right now because of the smoke and the recent fires in Los Angeles. So we now maybe will see if a large number of cases of sarcoidosis emerge in the next few months from the smoke and the fires. I know that there are people in the sarcoidosis community who will be looking for that. And then tattoos. Wow. If anyone is dealing with sarcoidosis that might be linked to having had a tattoo, would you reach out to me? Because I'd like to consider having you on the podcast and talk about that a little bit more. And then just one other thing about Dr. Yee. He's very, very easy to talk to. And while I was talking with him, and he told me this might happen, he said that one of the people one of the residents who's working with him had a patient in the other room, and then the interview might be interrupted. And sure enough, he's talking to me, and all of a sudden, here comes his resident, and she says, "Yeah, well, we're dealing with this patient." And then she saw, "Oh, you're doing a podcast," and she stopped and spoke with me a little bit. I probably will have edited that out because she was kind of far away from the mic. It wasn't easy to understand. But the fact that they were willing to talk through that with me, didn't reveal the patient's name, I didn't see the patient or anything like that, but just talked about it as sort of a case study to look at the situation that patient was having, and then we went right back to the interview. So just letting you know that we're right there where sarcoidosis treatment is happening with the podcast, and that's the first time that's ever happened for me, and having done this for over 3 years on the podcast. So yeah, it was kind of cool. And thanks again to Dr. Yee. I do want to say this is a good time to contact me if you would like to share your story here on the podcast, whether it's about tattoos or anything else you're dealing with, cardiac, neurosarc, pulmonary sarc, you name it. We want to hear your story. We want to hear your struggles. We want to hear your path to diagnosis. We want to hear what your life is like. now that you are dealing with sarcoidosis. So please contact me at carlinagency@gmail.com. The official Sarc Fighter song is Zombie by Mark Steyer and his band, the White Hot Lizards. You can hear Mark's story and how he came to those lyrics in episode 12, and an update from Mark and his sarcoidosis journey in episode 118. Normally, I release this podcast every other Monday. As I'm speaking today, my trusty dog Dougal, a boxer, is curled up in the chair in my office, as is Shandy, my adorable rescue mutt, and they make my life so much better. The backstory to the founding of the Foundation for Sarcoidosis Research is episode 11 with Andrea and Redding Wilson. Don't forget to follow me on social media. Just search for Sarc Fighter on Facebook, on Instagram. I'm even on Peloton as Sarc Fighter. And my cycling blog is called Carlin the Cyclist. There's a section called Cycling with Sarcoidosis. Also, if you're new here and just trying to figure out what Sarc is, try listening to episode 2 with Dr. Simon Hart. Consider that sort of Sarcoidosis 101. And my story is episode 1. Once again, send me an email if you'd like to contact me. It's in the show notes, carlinagency@gmail.com. Until next time, keep fighting.
Learn to suffer, you feel pain someday. Learn endurance, your strength will fade away. Dead man walking, trying to keep up the pace. Dead man walking,